Well, thanks for coming, everybody. How many have seen me in the office setting before? A handful. How many runners as a primary cardio? And other hikers, bikers? Just trying to get a feel for the audience. Swimming? Okay. How many of you had foot problems in the past? Sheepishly, she raises her hand. To expand a little bit, so I've been here 30 years. I would say biomechanics is a pretty significant part of my practice. I did surgical training and I still do forefoot surgery, but I don't do a lot of surgery. I don't do any ankle surgery. I don't do any hindfoot, but we have people in the community that can do that. Always did like biomechanics. I always liked trying to understand the science behind feet and the bones and the gait cycle. So I figured today and tonight would be a good topic, Biomechanics 101. Some of what I'll talk about you may have heard already, but if you have any questions along the way, feel free to stop me. My first slide is plugging Chris Smith. Clown shows up to the podiatrist's office and has concerns about shoes. So the tie-in, Chris, of course, is owner of 5 Star Sports. I do send a lot of folks down to 5 Star. I often get asked by patients for a brand name on running shoes or cardio shoes. And in the old days, I would universally say New Balance, in part because I think New Balance is a really good shoe. In part, it's been a good shoe for me. And then Danny, the previous owner, called me a few years back. How long have you been down there?
A couple years now.
Yeah, so it was probably 3-4 years ago. Danny called me, had me pulled from a room, and said, I just want to talk to you about sending people down, telling them they need New Balance shoes. And I was a little startled, and I said, well, is that a problem? Do you not want the referrals? He goes, no, it's a fantastic shoe. The problem is, if you send them down here and you told them New Balance, you've pigeonholed them. And I've just spent 45 minutes with them, and the Brooks Beast is the best shoe, but if you told them New Balance, they won't buy the correct shoe. And so that was a valuable lesson for me. So currently, when someone asks me about shoes, I might name 3 or 4 brands, but I will usually give 3 or 4 store names, because I think that's the most important part, is the fitting process, and I think Chris does a really nice job. This first slide talks or illustrates, everyone's heard about pronation and overpronation, and I think that word pronation and hyperpronation has become a really bad word. People hear it, they think automatically that they've got a problem. The fact is, we are all supposed to pronate. We are all supposed to supinate, and in the next few slides I'll illustrate what that's all about. But the way I think about these terms, this would be the noun. So as you look at someone standing, they're either going to sit neutral or normal. They're going to sit pronated. So if I was facing you with feet, the pronation, of course, is the collapse down and in, and the least common foot is the supinator, which is a foot that is up and out, really, really high arches. And so that's the noun, but the actual verb of pronation and supination has more to do with watching people walk and what are they doing during gait. Because you can have someone who is an overpronator that might collapse the medial side of their shoe, but the heel wear pattern is lateral. And if they see it lateral, then they think they're an over-supinator. The fact is, we're supposed to hit at heel strike supinated, and then as you come through mid-stance, you're going to pronate, and then as you get ready to toe off, you re-supinate. So textbook heel wear pattern should be about 3 degrees of varus or outside heel. So if you have really, really excessive outside heel wear pattern, you probably are over-supinating at heel strike, but it doesn't necessarily tell us what's going on through the rest of the gait cycle, if that makes sense. Obviously, if somebody comes in and dumps a bag of shoes and every single pair of their shoes is completely flattened out medial heel, medial midfoot, medial toe, without even looking at the foot, you know that that patient's an overpronator. That's all they do. They hit pancake flat and they come in, and guaranteed they're going to have calluses along the inside of the big toe and the big toe joint because they're just pronating completely through. So you've got heel strike, mid stance, propulsive, I call it toe off. That part of the gait cycle is only 60%. So that's the stance part, that's the part we all think about, but then there's this other swing part of the gait. But usually when we're evaluating and considering shoes and biomechanics, we're really most interested in the stance phase. So what can go wrong with feet? 26 bones, 33 joints, over 100 muscles, ligaments, tendons. I would say the vast majority of foot problems that I see are not acute and traumatic, they're overuse. In the world of bones, for the runner, stress fractures, the bones are so skinny at the forward part of the metatarsals that all it takes is considerable repetitive stress, and you can develop what we used to call a hairline crack, and now we call it a stress crack. Small crack in the bone. Typical presentation, you'll get a really localized area of swelling on the top side of the foot just behind the toes. Typically get a little bit of bruising. It's really quite sensitive. The good news about stress fractures, 99% of them heal uneventfully within 3 to 6 weeks, as long as they don't displace. I think I've only seen probably 2 or 3 displaced stress fractures, and one of them was in a track person years ago, an athlete for Crescent Valley that did, I think, the high hurdles, and on one of his high hurdles, things moved. But for most of us, getting a stress fracture is probably going to alter your training patterns for a period of time, but then you get 4, 5, 6 weeks out and it's done. It's healed. That's actually an easier problem to deal with, let's say, than a chronic tendon or ligament problem. Bones heal typically uneventfully, and tendons and ligaments, the overuse persists, and those are the ones that tend to go on. So I'll spend a little more time talking about tendon and overuse injuries, because I think for most athletes and runners in particular, it's probably going to be tissue-based as opposed to bone. Other things with bones and runners in particular, and to some degree hikers, there's 2 small bones under the great toe joint called sesamoids. They're part of the joint itself. The big toe joint is actually really fascinating. It's not one joint, it's 3. It's the main joint, and then each of those 2 little sesamoids have cartilage on the top half. So when your toe moves up, they glide forward, and when your toe moves down, they glide back. So they sit in a little groove there, and as long as that pulley system is okay and those bones are okay, who cares about sesamoids? Sesamoiditis is typically a running overuse problem where, similar to a stress fracture, you didn't do anything wrong, and all of a sudden there's intense pain under the joint. And that can last a long time, and typically with sesamoiditis, because it's a repetitive bone contusion, I will immobilize the athlete and put him in some kind of cast boot 4 to 6 weeks, sometimes crutches. And if you give that pulley system a chance to rest and you minimize the pull and tug on the bones, sesamoiditis is readily treated. It just takes a little bit longer than a stress fracture. Midfoot arthritis, I'll touch upon that briefly, just kind of looking at the audience. Most of you probably don't have midfoot arthritis, but I do see a lot of really active 50, 60, 70, 80-year-olds, hikers, not always runners, but active people. When you look at a profile of the foot, the high point or the apex of the foot is the midfoot, which is where the long bones connect to the cube-shaped bones, so it's the stress point. And all of our feet are doing the same thing as we get older. We are flattening, and the flattening apex is through the midfoot. So when we all develop midfoot arthritis, it's typically midfoot. Exceptions, rheumatoid arthritic patients tend to get it more frequently in the toe joints, but for the non-rheumatoid, it'll be midfoot. And that really can be a roadblock to running in particular. If you've got a moderate midfoot arthritis, you're probably going to want to look at cycling and swimming, just because the impact We don't have joint replacements like they do for knee and hip. In extreme cases of bone-on-bone midfoot arthritis, they sometimes do fusions. They'll fuse the entire midfoot, which is a big surgery with a big recovery, and you don't want it. Tendons, ligaments, definitely I see more overuse in the soft tissue department than I do bone. Probably number one on the list, of course, everyone has either had it or heard of it, plantar fasciitis. Really nasty problem. The plantar fascial tendon is a normal tendon that runs from the heel bone clear up to the toe bones. It actually has 3 slips, a medial slip, a central, and a lateral slip. The beefiest part of the tendon is where it tacks in and attaches to the bone. So probably 80% of my fasciitis patients, the pain is manifest in the heel, but 20% it's instep, sometimes heel and instep, and occasionally you will get people that get fasciitis symptoms up in the forefoot at the forward attachment. But the classic fasciitis patient, I didn't do anything wrong. I went to bed Monday, I woke up Tuesday, and I almost collapsed getting out of bed. It is significantly painful. It has this diagnostic feature of first step pain because the tendon is bowstring shaped, just like the foot is. When you're off your feet and not bearing weight, the natural foot position is to flex, and in that flex position, the tendon actually shortens and tightens. So rest doesn't make plantar fasciitis patients better. It actually allows things to tighten. So getting up out of a rested period, and of course sleep time is the longest time we rest, and that's why they invented night splints. I've got some brochures at the end if you'd like to pick one up. There are many, many night splints on the market. They typically fall into categories. There's posterior splints, there's dorsal splints, there's fixed 90-degree splints. In my opinion, this is the best splint on the market because it's a sock as opposed to a big boot. I would not recommend purchasing a fixed 90-degree boot. It's really hard to sleep in a 90-degree position. This splint is a stretch material. It's got an adjustable Velcro strap, so you get to decide how much correction you're placing. What the studies suggested was the perfect position for sleep would be foot to leg 90. So we're not going to allow this to happen, which means we're not going to allow the plantar fascial tendon to tighten. Of course, we don't live in that perfect world, so anything improved upon from the flex position is going to be helpful, and that's the great advantage of this one. With the Velcro tab, you can start out 10, 15 degrees, get used to it, go another 20 degrees. The other benefit of this splint, if you need to get up in the middle of the night, you can release the tab, you can walk in this splint. It's pretty difficult to walk in some of the other splints. I also brought some stretching handouts. The mainstay or foundation of treatment for plantar fasciitis, stretching, icing, splinting. My handout mimics just about everything you'll find on the internet. There's some really good videos on YouTube on plantar fasciitis stretches. So if you get plantar fasciitis at the front end, get a splint, start the stretching, ice probably once or twice a day. Anti-inflammatories, regular dosed, doesn't have to be high dose, but something for about 2 weeks would be helpful. If you're only dosing hit and miss, it'll take the edge off, but it never really gets up to therapeutic levels. Then what we do is 3-4 weeks later, if that's not enough, we start adding layers of treatment. We keep everything in place, and then we look into cortisone shots, physical therapy referrals, custom orthotics, sometimes boot immobilization. I don't typically boot my fasciitis patients, but it's not unusual for someone with plantar fasciitis for us to be treating them for months to get them better. But the end game is there's a finish line. You can fix plantar fasciitis. You just have to kind of stick with it and stay pretty aggressive. Achilles tendonitis, another tough one for a runner. The gastric soleus muscle on the back, as it tacks down into the heel bone, it is a pull-tug tendon, and every step we take in that gait cycle, that Achilles is pulling, and once that Achilles is inflamed, it really wants rest. more than anything. And so I have found that my go-to treatment for someone with chronic Achilles, and I don't see a lot of people coming in with 3 weeks of Achilles. I get the 6-month, 8-month, 2-year. Sometimes there's nodular changes in the tendon because it's been so chronic. I will put them in a boot, cast boot. It's a walking boot, but sometimes 6-10 weeks. And then that'll get them better, probably not all better, and then start transitioning them to physical therapy, sometimes custom orthotics. I don't inject the Achilles with cortisone. I do many injections with cortisone for plantar fasciitis because we've not seen problems with cortisone injection therapy and plantar fasciitis. And in fact, my success rate in treating plantar fasciitis would really drop if I didn't have injectable cortisone. But the Achilles is kind of a taboo spot. There are reports in the literature that putting cortisone in at the insertion can increase your risk for rupture of the tendon. So I know there's a few docs out there that do it. I don't do it. I don't inject the Achilles. So we kind of lose out on a big gun there. Another less common overuse syndrome and fairly unique to flat-footed people is if you're flat-footed or pronated. Again, if you think about the inside of the foot and ankle collapsing, there is a main tendon coming from the calf musculature called the posterior tibial tendon that comes down the leg behind the inside of the ankle, and it wraps around and it tacks into the navicular bone. And that tendon's purpose, or one of its main purposes, is to pull up and give you an arch and to help get your heel off the ground. So for someone that's been chronically flat-footed, there's this battle that's been going on for decades. Gravity, the foot structure, and the tendon countering or trying to counter. And typically in that war, the posterior tibial tendon will lose. And that patient will typically come in with a limp gait, an antalgic gait. Often, if you ask them to put a leg behind and try to go up on the one side, they won't be able to get off the ground because that tendon has been tethered and stretched to the point where it's not really functional. So within that syndrome, we actually see two types. Posterior tibial tendonitis would be someone who's just got tendon inflammation. They can still do the heel raise. And I would say, generally speaking, with boot immobilization and other therapies, we can get those folks better within a couple of month period. Definitely custom orthotics for those folks, posting them neutral or better so that they're not pronating. The person that can't get off the ground, they are now classified as having Pttd, posterior tibial tendon dysfunction. If they can't do a heel raise, it tells us without an MRI that that tendon is dysfunctional. It's currently not working. And typically that patient is not only baseline flat, then they'll go to a foot that rotates out, and when you watch them walk away, you'll see they just sort of drag it. Those folks will typically start out with boot therapy, immobilize them, but if they're not responding, then an MRI, and sometimes those folks will have a split tear in the tendon. Sort of like a rubber band that's been tethered for so long that it develops those sort of intrinsic little tears. Tendons can do the same thing. They're called split tears or longitudinal interstitial split tears. And for that patient, sometimes it's a surgical fix, which I don't do, but we've got a good fella here in town that I can ship out to. So I would say fasciitis, Achilles, and posterior tibial tendonitis. Peroneal tendonitis is the outside tendon. So the posterior tib is on the inside and the peroneal tendon is on the outside. If we're going to stereotype the pronated foot, if they're going to have tendon-based problems, it's going to be on the inside. It's going to be the posterior tibial tendon, almost always. If you're a high-arched supinated foot, now all of the stress is to the other side, and so that'll tag the peroneal tendon, which comes down and inserts. There's a bone prominence on the outside, about middle third of your foot on the outside. You can run your finger. And that prominence is there for a reason. It serves as the attachment for the peroneal brevis tendon. And in really high-arched supinated foot, typically if I'm seeing that patient and they've got an overused tendonitis, it'll be the peroneal tendon, not the inside tendon. Sometimes Achilles, but peroneal tendon. And then there is about a 25% cross incidence in people that have chronic plantar fasciitis, and almost everyone that's got fasciitis has chronic plantar fasciitis. But in about 25% of the people, because of compensation, they will get a secondary tendonitis, and usually that'll either be the Achilles or the peroneal tendon. But fortunately, in that patient, everything we're going to do, we don't need 3 different lines of treatment care. All the protocols are about the same. So I found this one. I thought, well, this is pertinent. I do see a lot of athletes, cyclists, triathletes, you name it. And I don't like pulling people from what they like to do. But I do believe in cross-training. And I do believe there's a happy medium somewhere, so that if you are busy training for a race and something comes up where maybe running is not the best thing, maybe we start by scaling down the running, maybe the duration, maybe the frequency, and we throw in swimming, we throw in cycling, because I will tell you, with all of these overuse syndromes, it is way easier to deal with those and get a good cardio swimming or cycling or using stationary machinery versus running or treadmilling. But my goal with my runners is I want to identify what the problem is, I want to get them better, I want to get them back to running. About the only time I'll pull a runner and make it sort of a unilateral decision, if there's a stress fracture that appears slightly unstable, I'm going to pull the runner and put him in a boot and tell him you can't run. Because the last thing you want is for that to displace, and now you need surgery to get in there and graft it and fixate it, and now you're out of commission for 4 months instead of 6 weeks. As I mentioned in the beginning, my favorite stores in town for shoes, 5-Star Sports if you're looking for running shoes. If you want something a little bit dressier, then the Shoe Hutch right next door. And if you want something a little more European or a clog, then Footwise, what everybody calls the Birkenstock store, but it's actually Footwise. Within 2 blocks of each other, those are really good stores. They've all been in business a long time. I think they do a really good job fitting people, which I think is important. So on that note, I'll have Chris talk about shoes. Any questions for me?
I have a question.
Sure.
So you were talking about doing cortisone injections for plantar fasciitis?
Mm-hmm.
So is the purpose of that to pretty much, while that cortisone injection is doing its magic, to strengthen your plantar fascia during that, or just fix it on its own?
No, so the way I think about cortisone, it's an anti-inflammatory. Okay. So everything we do in tendon inflammation is designed to reduce inflammation. Okay. Icing, compression sleeves, Advil, and cortisone is on that list. It's an anti-inflammatory. So it's not a mask, it's not a narcotic. But I'm really careful, if someone's really gun-shy about an injection, or actually with all my patients, I tell them, for plantar fasciitis in particular, you've got this horrible problem. We've got a tool bag of treatment. There's 8 or 10 or 12 different tools. Cortisone injection is one more tool. It's not anything special. It's just another tool in the tool bag. But I would say that if someone's coming to me and they're going to Europe in 3 weeks and they're going to go on a walking trip, or they've got a really important race in 3 weeks, and they come to me as a new patient and they want to know, what can you do for me today, doc, so that I can race in 3 weeks? I'm going to have them do all of this, the injection, top of the list. I would say custom orthotics, probably top of the list for the long term, but the injection has the greatest potential of the magic bullet. It's not that for everyone, but it can be. So. Anything else? Chris?
All right. So my name's Chris. I'm the owner at 5-Star Sports in downtown Corvallis. I'm basically going to be here to talk about the shoe types and kind of the idea about what we do with regards to those overuse injuries, so you're not running into those potential problems that Dr. Murphy was talking about. So our main goal is to look at your form, the biomechanics of your foot, so that we can get an idea of that category based on what you're training for to give you the right recommendation. So the potential for those injuries is going to go down quite a bit. So I'm actually going to grab some of these samples so I can kind of go over that.
Quick question.
Go for it.
So when you're checking out my movement for a foot for running, would that cross over to bicycling?
It's a little different. The impact in running is definitely going to be quite a bit higher than it will be for somebody that's bicycling.
Well, I monkeyed around with my bicycle shoes myself.
Uh-huh.
I'm learning from tonight. I know nothing about what I'm doing.
Okay, so and then overall, the other thing is going to be that where your pressure points are with running are going to be quite a bit different with regards to where your pressure points will be when you're biking. So a lot of that force is translated when you're biking through the forefoot because of where that pedal is placed. Depending on your form with running, that's going to be the biggest indicator for what you're looking for in shoes that way. So when we look at people, when we evaluate people, we run them through kind of a video gait analysis. We'll do kind of a general static dynamic test that takes the foot unloaded into account. Then we'll look at it loaded, so we'll have you stand to get an idea what body weight looks like. And then we'll go dynamic. We'll watch you walk, we'll watch you run. We want to get an idea where those movement points are, where if there is mobility. And then the other thing we're looking at is your form. When we start accelerating, going from a walk to a run, your form can definitely change. Taking that into account, it's going to be something that we want to watch you run so we can see category-wise what that lines up with. Once all those variables are kind of put into one, we take into account, category. So if you're training for something trail, you're going to want something featured-wise in a shoe that's a little bit different when you're training for something that's a road-based shoe. If you're a walker, a hiker, you're not going to maybe want something a little bit more robust than somebody that is looking for a little bit more speed-based. So overall, we're taking a lot of those things into account when we do that gait analysis. And then once we do that, we usually give you a handful of shoes to try on and kind of go through the process of figuring out which one you feel fits your foot the best. The idea is to kind of take 90% of the shoes on the wall and remove them so that it's easier for you to make that decision based on what you feel fits the best. Once we do that, like I said, we'll typically figure out and say this category based on your biomechanics, based on your form is what we're gonna point you towards. Most brands are gonna make their representation of that category in a couple different price points. So those are definitely things that will come into play for different customers, depending on what they're willing to spend and what sort of features they're looking for. For the most part, price points are going to dictate technology. The newest technology is going to be the most expensive. Most brands are going to want to recoup what they're getting out of their shoes, out of those shoes first, and then let it trickle down into the other stuff. The other thing that will dictate that is cushioning. That's the other main factor when you go from specialty shoes, is that in their kind of intermediate to entry-level price points, it's going to be a little bit less cushioning in something that is at their kind of top-tier price point. Categories we're looking at right now, if I had to say, I mean, we have 4 categories on our walls. That's kind of how most brands will categorize their shoes. There are kind of subcategories within categories based on what sort of technical features the shoe gives you. So right now there's about 4, but I would say there's up to about 6, depending on whether or not you wanted to call it a subcategory or not. So if we were looking at kind of a full-length spectrum of a shoe or how shoes were constructed, from basically no support all the way up to the maximum amount of support you can get in a shoe. The first category would probably be those minimal shoes, very popular back in 2005. Everybody's probably read Born to Run or heard of it and heard of the shoes that they were talking about in that. This is really kind of a non-existent shoe at this point. Probably 3 or so years after that book came out, you started to see these kind of go away. A lot of indicators being that injuries with regarding to that, even if you're doing it correctly, the way that the foot is designed, again, kind of like Dr. Murphy was talking about, you get a lot smaller bone structure in the forward part of the foot. It's something that when you go through a real drastic change as far as what your form is concerned, mostly going to be kind of an emphasis on getting on the ball of the foot to kind of take stress off of the rest of the foot. It's something that with harder surfaces the body just doesn't like dealing with. So those are, for the most part, you don't see them all that often. I want to say it was something along the lines of, I read that metatarsal stress fractures went up upwards of 250+% the year after that book came out. And it was mostly because there was just a lot of bad information being passed around. People weren't approaching it correctly. So that is an example of what is there. There's still a few, and admittedly, there are a percentage of people that can get away with that, but they're just a very small percentage of the running population. It's just not a lot of structure. It's a very low offset. So you understand what offset is. It's the difference in the stack height of the heel compared to the forefoot. So most what they call shod platforms, something that's designed for somebody that has more of a decelerative impact, somebody that heel strikes, those are going to be in that kind of 10 millimeter, 12 millimeter range, give you a little bit of a buffer underneath the heel to kind of help dissipate that impact and transition you forward in the gait. Most of the shoes now that you're seeing that are in that kind of minimalist range are in that 0 to 4 range. Very flexible, not a lot of cushioning. This has evolved into this. So it's still a relatively low offset shoe depending on the brand, what they're going for with it, but it's more of a transitional category that we call it now. So you're getting those low offsets for people that are really working on their forms. You're just getting a little bit more of a traditional stack height. You're getting some cushioning in the shoe to kind of help dissipate that force, especially with regards to harder surfaces where most people are running based on convenience. You're getting something that's still light and flexible. You're just not getting something that's going to be as hard on your foot as something that has very little underneath it. These are meant for people that are, racing, speed work stuff that's going to be a lot more focused on go fast. The person that is very neutral in their gait, those supinators, underpronators, neutral runners, not a lot of overpronation. You will get people that have pronation that prefer going this direction. The inserts are always an option. I don't recommend doing something along those lines of volume training and something like this if there's a lot of motion there, but it is an option for people if they tend to prefer this type of shoe based on the fit or the weight. The next step up in that spectrum would be neutral. Again, very similar to this, but a lot of these shoes are going to be a little bit more traditional in their stacks and their offsets. And the other thing that really comes into play there, again, you're seeing a lot of brands trying to focus on, in order to differentiate themselves, focusing on offset. So majority of the brands are still going to get that kind of more traditional offset, but they're all messing around with it because they all have biomechanics labs. They're doing a lot of stuff with regards to testing, and in order to kind of figure out what shoe is going to sell the best for them, you're seeing them mess around with those slightly lower offsets based on what they're finding with regards to that data. But even then, you're still getting those traditional stacks. Most of the time, nothing really lower than about an 8 mil offset. The next one would be not necessarily a change in the overall construction of the shoe, but something that's a little bit more trail inspired. A lot more lugging in shoes along these lines, made for off-road, lots of ascending, lots of descending. You get a flatter sole for more contact points with the ground, gives you a lot more stability with kind of varying terrains. Some of them will have ballistic shields, protecting those kind of smaller bone structures from harder surfaces such as fire roads, those rocks, those roots that will come up and get you in runs. And then reinforced uppers. They want to keep your foot a little bit more stable in those platforms. You don't want to slide around as much, so they're typically a little bit lower volume reinforced, so you're not getting quite as much stretch in that shoe. From there, you've got kind of the new kid on the block, the Hoka. These are getting into the maximal stacks. You're getting upwards of 32 or 33 millimeters underneath your foot. So they originally came out probably 6 or 7 years ago. Actually, probably been longer than that, but they've been relevant for about 6 or 7 years. Quite a bit different construction-wise than most traditional shoes. They originally came out to kind of cater to most of the ultra marathoners, longer distance, people out there for 100+ miles. They wanted to help dissipate as much of that vibration fatigue that was happening over time as they could. They've got a relatively unique way of doing that with those maximal stacks. They also have kind of a lower offset, and so because of that, the shoe is very rigid. You don't get a lot of flex in that platform from heel to toe like you do some of the traditional shoes in order to kind of move you forward. So because of that, they have kind of this rocking mechanism involved. They call it a meta rocker. Help propulse you forward so you're not fighting that platform nearly as much. It's very unique. It's got a lot of unique categories that it's kind of driven itself into. They started off one silo trying to kind of cater to that particular category, and it's really branched off from there. Now, with a lot of stores working with podiatrists and with focus on particular sets of injuries that a lot of runners run into, you're kind of seeing that this type of shoe will address some of those particular sets. And it's been really good because a lot of the other shoes that are traditionally manufactured they don't do a very good job in certain areas. So we've seen this hit a subset of injuries that we've really never been able to address quite as well. It's always been something different, like a carbon fiber shank in the shoe to kind of limit flexibility, adding certain things like arch supports or even more cushioning to shoes in order to kind of limit certain movements that the foot is doing. And so this brand's definitely kind of taken advantage of that kind of niche. So it's been really good. The next step up, and so again, sorry I've messed, these are all for neutral. Trail will be mostly neutral. I'm not really sure why brands think that a lot of people don't have, or that people that overpronate don't run trails. We see a large spectrum of people, or a good portion of them, that have some overpronation that want to be off-road based on where our location is, and they're having to kind of address it a different way because most of the brands are creating these trail shoes that there's just not a lot of structure to the shoe. In order to kind of explain that, for somebody that does overpronate, the category that they gravitate towards, or that we tend to push them towards, is a shoe that's stability oriented. And in order to kind of slow that pronation within the gait cycle, the shoes are designed to have what they call medial posting in them. It's denser material that's kind of underneath the ankle in that subtalar region up into the kind of just before the metatarsals, and it's meant to kind of slow that motion down. It's again that overpronation and excess and in repetition that's usually linked to a lot of the overuse injuries that a lot of runners that kind of have that rear-footed impact will run into. And so if you can slow that motion down, usually you're going to run into a lot less of those overuse-based injuries. You don't see this type of shoe in a trail-based category for whatever reason. They've decided that either the terrain varying is enough to change your biomechanics, that it's not a necessity. Personally, I see enough people that it still would benefit, that I wish they would, but for whatever reason, it's kind of that unicorn. Every year we're waiting for somebody to come out with that stability-based trail shoe, and it just doesn't happen. These two are probably where most people fall. You get upwards of probably 45% of people here, and probably another 35 to 40 in that neutral category. The last one is going to be motion control. This is for those people that have lots of mobility in that arch, really flat feet, really hard impacts. Dr. Murphy was talking about a lot of those real flat-based foot injuries. This is usually a shoe that he's going to be recommending because of how it immobilizes that foot. The idea is still the same as a stability shoe. it's just a lot more linear of a platform, so you get a lot more foundation. It's just going to help stop that foot from moving as much as possible without casting it like you would a boot. And so the idea is, again, isolate, slow that overpronation, stop it in excess so that whatever that person is trying to move towards with regards to exercise is not going to be causing any sort of injury. From there, we've also got something that tends to get recommended relatively frequently, and that's kind of an over-the-counter orthotic. The idea is still the same as a custom. You get a shank that's designed to kind of give you that floated arch, something that kind of casts the bottom of it to kind of limit the amount of flexion that's going to occur. It's just a lot more static than a shoe would be. Shoes are very dynamic in their support structure. You kind of have to be moving forward for those things to activate. This is just a lot more encompassing. So things like plantar fasciitis, it's going to be something where, again, anytime you go weight bearing on a tight tendon, it's going to cause some pain. This is going to be something to kind of isolate that foot, stop it from overstretching too much, keep it kind of in its natural state so that you don't get that pain, that overuse. It's going to protect it in kind of all phases rather than in a just gait cycle like the shoes will. These can go, we do them in a lot of things. We don't tend to do too much in the motion control unless there's kind of it falls into like a small little percentage of our customers that we're really trying to isolate that foot because of excess mobility. But every other shoe, it really will fit in except for something here because it's kind of counterproductive. And the idea is to get something that, again, matches your foot as much as possible. It's not a custom like you're going to get from a podiatrist or a physical therapist that can do that. It's more of your kind of general purpose over the counter, match the arch as closely as you can and put it in that footwear that you're kind of trying to get that benefit from.
So if someone was really interested in a trail shoe,
this is really,
they would need that to.
If most of the features that they're focused on, they're going to get a benefit from being trail based because most of the stuff they're doing is off-road based and they need structure in the shoe, then usually the only way to get it is by adding some sort of insert to a trail based platform. Correct. Yeah.
So do you think instead of wearing like orthotics, if you just strengthen your foot a certain way, to the point where you don't need orthotics, do you think that's just as efficient, like as a podiatrist?
Well, there are those that aspire to that theory. I'm not one of them. And I'll go back to the minimalist. Having no shoes or very little in the shoe is a minimalist approach. And I would echo what Chris said, that when this trend hit us a few years back, I had already been seeing a ton of overuse sports-related injuries.
Yeah.
And those numbers went up in my minimalist people. So no, I don't think you can train the foot to prevent injury. I think, stretching, range of motion, there are certain things you can do, but I don't think that's a substitute for a good shoe and a good orthotic.
Okay.
It never panned out with the minimalist approach.
So for like orthotics, is it like a lifetime thing, or is it like you wear orthotics until you're not injured? And
Well,
you wear yourself off of it?
It depends on the problem. If somebody's an overpronator and they've battled a lifetime of overpronation problems, PT tendonitis, medial knee pain, hip pain, they're probably going to want to wear them forever. It's like glasses.
Okay.
You just use them. Having said that, most of the custom orthotics I build for people, I would say my patients that have customs wear them 50 to 75% of the time.
Yeah.
Because they're in certain shoes, Birkenstocks, Danskos. There are many good shoes out there that are not orthotic friendly.
Oh.
Orthotics need a home. It's got to be closed, it's got to be deep enough. And so they don't go in Chacos, and I love Chacos. I send a lot of people down to Peak Sports for Chacos. Probably one of the best hiking, walking sandals that you can use during the summer months.
Yeah.
Who wants to wear sneaks and orthotics in summer?
Yeah.
So.
Awesome. Thank you.
And I would echo kind of what he said. In my experience, it's a situation where it kind of depends on the person. Beginning runners that that are kind of new to it, that don't have a lot of joint dysfunction, they probably aren't going to be super reliant on that if they can kind of get stronger and get more accustomed to what they're doing. But if you've got somebody that's got a lot of injury, a chronic injury, a lot of issues with mobility and joint dysfunction, they're probably going to be to some extent reliant on that, depending on what they're going for.
One of the things that I see oftentimes is people have been doing something for a long period of time, they've never had any problems, then suddenly they get a problem. And whatever that problem might be, we can generally treat it and get them back to what they've been doing for 20 years without problems. And so oftentimes people will come in, they've had flat feet for their whole lives, and then suddenly they have some other problem. And I'm not going to necessarily make a lot of changes because their foot's been fine for 20 years despite the flat foot. If we can resolve that problem, they can go back to running with a flat foot, and if they don't have that problem ever again, if they don't have any new problems, then they're perfectly fine. So a lot of the times there's a very temporary time for doing NR support or a treatment, and then you can get back to how you've been for the last 20 years, and there's no need to continue in NR support for a long period of time.
And there are times where there are problems identified that don't need to be treated. For example, I do see this frequently. Somebody gets referred to the physical therapist with problem X. And as they're there and being evaluated, and therapists are really, really smart people and very good at what they do, but they're there with problem X, and the therapist has identified that the patient has a limb length inequality. Patient's 50 years old, has never had any problems related to limb length, but the problem has been identified, and the literature is pretty clear that most of us do not have equal length limbs, plus or minus ½ centimeter. If the patient's not symptomatic, you don't want to be treating someone who's 40, 50 years old that's been that way their whole life by putting a heel lift in. It's different than the patient who's got a hip replacement and all of a sudden they've got a surgically induced significant limb length. That limb length needs to be treated.
Yeah, it's different. Yeah.
Right in the front.
Yeah. Makes sense.
So as I sit here and listen to all this, I was in a motorcycle wreck. The car bumper pinned my right foot up against the bumper in my motorcycle. I broke 3 bones. They said I would never walk without a limp again. Well, I proved them wrong there. But I ran a marathon and pulled the Achilles tendon on my left foot, and I'm sitting here wondering if the two have something to do with each other. And should I start with a doctor like you or go to the shoe store to start?
Go to him first.
Well,
You want to get it evaluated for sure to make sure that it's.
Because I want to keep running.
I mean, you could, there's a lot of good information online. There's a lot of bad information, but there's good information, and I think if you are just a little careful about filtering certain things. So if it's a run-of-the-mill Achilles tendonitis, and I'm not saying that to belittle what you have, but if it's a run-of-the-mill Achilles tendonitis, you're probably going to start with stretching and icing and a heel lift. I'm probably not going to have you run. I'm going to have you loaded up on anti-inflammatories, and we'll go 3 to 4 weeks to see if we can make you better. And then if not, we're going to get more aggressive. We'll put you in a boot. We might send you to the physical therapist. We're going to talk about orthotics and shoes for the long haul. But if you showed up in my office and had an Achilles that was flared, I'm going to be doing those first few things with you and hope that within a reasonable period of time you're better.
I just rested it and did a lot of bicycling.
You're going to get some Achilles motion with bicycling, but certainly that's a better choice than running or treadmilling if you've got Achilles.
Now, after a few years, it's not bothering me anymore.
But I mean, it could have been related to the original injury if that original injury created any sort of delayed compensation.
Yeah.
But we can't change that.
So I guess go to the shoe store, get some shoes, and if I have a problem, then go back to you.
I would gently stretch it. I would ice it. Maybe get a little heel lift. You can buy heel lifts over the counter.
It's not bothering me at all now.
Yeah, then you probably don't need to treat it.
So if we're coming down to get shoes, should we bring a pair of really worn shoes for you to see the wear pattern?
It's not a necessity.
Just don't bring 20 pairs. Don't
Yeah.
be that person.
It's not a necessity. but it definitely helps. If we can see something that you've been wearing and kind of what that wear pattern shows, it'll show us how your movement through that particular category of shoe, that wear tends to show, you know, what your gait looks like. So it definitely will give us an idea of if you've used something specific in the past, whether or not it's worked, and then what that wear pattern looks like. A lot of times at the beginning part of the gait cycle, we'll get situations that will be kind of on the fence based on what we're thinking until we throw you on the treadmill, get you at higher impacts if it is running that we're focused on. But for runners, there are certain people that, again, Dr. Murphy kind of pointed at the beginning, is pronation is kind of a word that everybody knows now because of particular types of injuries, and it gets demonized a lot. And so you want some there in order to kind of help your own body dissipate the force of its weight hitting the ground. When we're doing kind of that static dynamic test, there are people that will see either no motion at all or maybe a little bit of motion to the extent that when you're barefoot, your body's ability to kind of buffer is a lot better than when you have a platform underneath it. It's called proprioceptive response. And so it's a lot easier to kind of impact. You're not going to really slam the ground because you're not really sure what's underneath it, compared to when you've got some cushioning. So with that being the case, there are times that we'll think something until we throw you on the treadmill and then say, okay, never mind, that's kind of changed. So it definitely will help kind of push us in a particular direction, but it's not a necessity.
So do you have to come in and ask, say, I need help?
Well, it'll help. But pretty much all of our customers, unless we've worked with them already and they kind of know what they're looking for, it's kind of the idea. That's what we do as a running specialty store. The idea is to kind of help people who are walkers, runners, hikers, that if they're having problems and they don't really know where to look or how to address it, we can kind of point you in the right direction.
So if I buy a pair of shoes tomorrow, is that long enough to run this 5K at the end of the month?
As long as you're not too far away from where you're at with the current shoes, you know, break-in times, you know, it's shoes nowadays are pretty much ready to go right out of the box based on what they're made out of. You know, 20, 30 years ago when they were made out of polyurethane and a lot of people talked about break-in times, that's a lot denser material, a lot more substantial material. That was something that definitely required kind of getting used to and kind of having your foot adjust to that rigidity, that shoe kind of get used to the foot in it. Most of them nowadays are going to be ready to go out of the box. If it's a pretty drastic change from what you're used to, depending on how much time you have, I probably wouldn't suggest it. You know, but 2-3 weeks is plenty of time. As long as your training is there and the shoe doesn't change too much, you're not going to have a problem.
So why did you say that there was, like, Brooks, was it Beast, was like the best running?
New Balance.
Oh, was it New Balance? Why?
For me, that went back a number of years because there was a period of time going back a decade plus where finding a good quality walking/running shoe that was wide enough, there were very few options out there. And New Balance, long before anyone else did it, they had width, they had depth, they have width. And many of my patients need orthotics, whether they're over-the-counter or custom, and orthotics take up room. And so New Balance was a well-made shoe. It was a shoe that was really receptive to orthotics.
I thought it would, like, depend on the person that's buying the shoe, but I can see where you're saying,
But
because it
I-
fit a very various different
Yeah,
situations, is what you're saying.
Yeah, there are many
Yeah.
great brands out there, but I do still get many patients who come in and they want me to give them a brand name. They want
Oh, I see.
some leadership. They want, what shoe should I go buy? Go down and talk to Chris.
If
Okay.
I can jump into that one for a second. You know, having been in the shoe labs, the ones you're speaking of, they're designed for different people. And in any given brand, there's a number of dogs for you.
Yeah.
But in any given brand, there may be the exact great shoe for you. And next year, the same name shoe, Nirvana or whatever it is, might be a different shoe. And so it's a pretty dynamic process.
So you get what you like, you buy 3 pairs.
Well,
Now you can go on Amazon and buy old
and
ones.
that's not all that bad
No,
of
if
an
you find
idea.
something you really like in a good shoe, you should go back and buy 2 more pairs, because they'll change them. They will, the companies are constantly moving target.
But they still have them, and now with Amazon Internet, you can find them.
Yeah. The Amazon Berry.
So I should throw away the fact that I used to run barefooted all the time.
It's not a bad thing for you if it's not causing problems.
I tried it on the treadmill. The only thing that I didn't like, the coarseness of the treadmill was tearing up my skin.
So what do you think of socks? Because nowadays they have socks for runners and like, of course, like they say no cotton socks, maybe socks.
That's the main focus, is a lot of socks are going to kind of help limit the amount of friction that's occurring when that foot's moving in the shoe. When you start talking about increasing duration and distance, there's a lot more sweat that's involved with the foot, a lot more friction that's involved, and so the idea is to kind of help mitigate that by pulling that moisture away from the foot. So socks can be important. I don't really put a huge emphasis on it if blistering is not an issue, and we tend to push people away from cotton in general because that's what will cause that issue. That natural fiber just kind of holds the moisture next to the foot. Something that's a treated poly or a wool is going to be technical enough to kind of pull that moisture away and limit that friction. But overall, I'm one of those people that I'm usually not going to push something onto you that's not a necessity. So in a situation where blistering is a problem, then we'll usually start with socks, and then we'll look at some sort of barrier to that friction, like a body glide, some sort of friction-based lube to kind of limit the friction that's happening in a particular seam point or something along those lines. But they can be important, but for some people it just doesn't make too much of a difference. You know, if you're running shorter distances at higher speeds, sure, but most people that are running that kind of 5K distance, 10K distance at a relatively decent pace, cotton will be just fine. You usually start to be a problem when you move up into kind of the longer time frames.